I'll be speaking to you now about the Affordable Care Act, also known as the ACA, and arguably one of the most important pieces of legislation to be enacted since Medicare. As many of you know, the ACA is first and foremost legislation designed to increase insurance coverage throughout the United States. Originally, estimates were 16 million people in the Medicaid population and a comparable number or maybe more in the private insurance markets, encouraged by subsidies and the individual mandate. And though the difficulties we've had with the computer programming to get people in may bring that number down for the first few years, we're still hopeful eventually we'll get a substantial increase in the amount of insured Americans. But the ACA includes a substantial number of other provisions, a large number of other provisions that together promise to change the delivery of health care in America. I'll be talking about a series of provisions that relate to quality of care. One is integration of care, 2 is incentives to improve quality, and 3 is tools to help us make wiser decisions and improve quality of care. In terms of integration, perhaps the most important part of the ACA are the provisions related to accountable care organizations, ACOs. Many of you may have heard of these, in which individual doctors, other caregivers, hospitals, nursing home, long-term care, community health centers are encouraged to come together and form a single unit or group in which they agree to undertake care for a defined population of Medicare patients, meet quality standards, and when they do that, share in some of the savings, or in some cases, in the out years, share in some of the overages. Now, in some ways, the shared savings model of ACOs represents a grand compromise in healthcare payment reform. On the one hand, we've got fee-for-service payments, which is how the indemnity system usually works, which makes everybody worry about overuse. And on the other hand, we've got capitation, which makes patients worry about underuse and makes providers worry about they're going to get appropriate reimbursement. And so shared savings is designed to thread the needle. And then we all have appreciation for the benefits or the potential benefits of integrated care, of getting doctors to talk to each other about the patient and to make transitions across different forms of care, inpatient, outpatient, seamless. But the news may not all be good, because integrated care may also bring about consolidated care with fewer organizations, and fewer organizations may mean less competition, and the Federal Trade Commission is worried about that. And the government, which ran a multi-year demonstration before it adopted ACOs, of an ACO-like program, found that the organizations were able to meet quality standards, but many of them fell short of shared savings, of meeting shared savings at all. And so we're not sure how this will turn out yet, but it's an important component of the ACA. Another important component designed to move us towards integrated care is bundling. Again, asking doctors and other providers and hospitals and long-term care organizations to work together, receive a single payment for a patient who's getting a procedure such as coronary artery bypass graft surgery, total hip replacement or total knee replacement. And the idea being that they will not only divide that payment in a reasonable and equitable way, but they will design care more efficiently so that they'll be able to deliver that care in a way that is better for the patient. And finally, there are provisions in the ACA to change payment for readmissions. Hospitals which have large numbers of readmissions within 30 days, large numbers compared to what one might expect for the numbers of patients they see and the illness of those patients, they'll be penalized. And what's really interesting about this is we're not just talking about readmissions 24 hours after discharge, 48 hours, or 72 hours. We're talking about readmissions that may be as long as a month away, when patients' care is usually transferred to outpatient providers. And so this is a clear message to hospitals that they've got to get together with outpatient ambulatory providers and design care so that they're working together more efficiently. We've already seen changes in delivery system that reflect these incentives. You can see from this slide, which shows the numbers of hospital mergers and acquisitions, that there's been a substantial increase since 2010, with the numbers going up substantially and nearly doubling since 2009. And more mergers and acquisitions mean larger size organizations and supersizing of hospitals. And we've seen change in ownership. The majority of physician practices today are no longer owned by physicians. They're owned by hospitals and other organizations. Tremendous change in our care. Well, it's not only changes in terms of greater integration that we're seeing, but the ACA has adopted a series of incentives for better performance. One is an expansion of the existing programs of publicly reported quality performance. CMS, the Center for Medicare Services, already has a site called Medicare Compare, which reports on quality of care by hospitals. But now there is a mandate out to take that site, increase the number of measures, and over time move it to other providers, including long-term care and physicians. There are existing programs that provide financial incentives for better quality of care. They're called Pay for Performance. The government adopted in the fall of 2013 a Pay for Performance program for hospitals called Value-Based Purchasing. As part of the ACA, that program will be expanded with a broader set of measures and more money at stake, and eventually, again, to other providers of care. You can see some of the power in publicly reported information from slides like these. This slide shows mortality rates for patients with congestive heart failure. I've chosen 3 local hospitals: the Brigham and Women's Hospital, the Mass General Hospital, and the Beth Israel Deaconess Hospital. And if you look at the slide, you'll see that all the ratings are way on the left and in green. The death rates are all lower than national average, and green means go. That's a good thing. This slide shows rates of readmission for congestive heart failure patients. And on the right, in red, is the rate for the Beth Israel Deaconess Hospital, higher than national average. Red means stop. And we can expect to see data like these and over a much broader array of measures becoming more and more popular in the years ahead. Now, incentives to improve quality of care only will take us so far unless doctors and other caregivers have tools that will enable them to be effective. And so the Affordable Care Act has established provisions for such tools. One of them has been to use greater use of electronic health records. And this actually really predates the ACA. The stimulus package included more than $20 billion in funding to provide incentives for doctors and hospitals to adopt electronic health records. This slide shows the impact on ambulatory electronic health records, a clear bump when incentives started. And you can see that's even more pronounced for hospital electronic health records. I don't know whether we've reached a tipping point or not, but it's clear we've made remarkable penetration and increased penetration in electronic health records and their use to improve quality of care. Finally, the ACA included provisions that establish PCORI, P-C-O-R-I, the Patient-Centered Outcome Research Institute. This is an organization dedicated to funding and supporting comparative effectiveness research. You could think of it as a complement to the kinds of basic research and translational research usually performed by the NIH. This research is designed to provide information that will be useful to doctors and patients and their caregivers at the point of care. The board is multicentric. It includes researchers and patient representatives and physician representatives and nurse representatives and representatives of health plans and device manufacturers, pharmaceutical firms. And the amount of money has been substantial. It started in 2010 with only $10 million. Next year, its funding will be over $500 million, $500 million or more going for this type of research. And so in summary, there's a takeaway here, which is not only is the ACA a bill about expanding insurance coverage, but it's a bill about fostering greater integration, about promoting quality improvement, and providing tools for doctors and other caregivers to work with patients to make wiser decisions and to give better quality. And it's starting. We're going to implement the ACA over the next number of years, but I expect the implementation won't be perfect, and we'll be making changes to accelerate this process over time. What can you see as a patient? Maybe you'll notice that your doctors, your primary care doctor, and the specialists you see will be better in touch, or that your doctors and the hospitals that you might go to might have better communication, or that transition from one sector, outpatient to inpatient, is done more seamlessly, or that there's more publicly reported information, or that you and your doctor have more information that you need to make wiser decisions. That's the reality I hope that all of us will be seeing because of the changes in the ACA.